Good morning and welcome to today's question of the day. Feel free to put the recording on hold while you answer this question. As is apparent, this is a data-driven question. The vignette has the usual supporting demographics and requisite tomfoolery, but it is interpretation of data that will get you across the finish line on this question. And so what do we have? We have a flow volume loop demonstrating restrictive lung disease. Once you identify this as restrictive lung disease, interstitial fibrosis is the only disorder in the question options that would generate this finding. So today's take-home is to both interpret the flow volume loop and perform the clinical correlation with a restrictive disorder. Insofar as interpreting this curve, if you just focus on the residual volume on the right part of the curve, you'll have no difficulty distinguishing between restrictive and obstructive disorders. And if you compare and contrast these curves, if you start with the restrictive curve and look to the right, you can see the volume has decreased consistent with a reduction in residual volume. If you compare that with an obstructive flow volume loop, you can see the residual volume increasing, as is the total lung capacity. So if you just focus on the residual volume, you'll have no problem making distinctions between restrictive and obstructive curves. In terms of what the flow volume loop shows, it's much more than just the residual volume, of course. Here the patient takes a deep inspiration and then blows out rapidly, as represented by expiration on this curve. Within that curve, you'll see the vital capacity combined with the residual volume will give you the total lung capacity. Coming back to restriction, you can see again the key element of decreased residual volume, which also correlates with a decrease in total lung capacity, decrease in FEV1, and a decrease in the vital capacity. But the important take-home is also this preservation of FEV1 to FVC ratio that is characteristic of restrictive lung disorders. Insofar as interpreting the incorrect options, we'll start with cor pulmonale, and I always encourage you to put in the typical associations or buzzwords. In a patient with cor pulmonale, you can expect the presence of JVD and edema. Here in this vignette, the cardiac exam is described as normal. So that option is eliminated by normal findings on physical exam. Here comes the tomfoolery that is often embedded within the verbiage. We know that this patient is a smoker, and they offer cough-productive scant sputum. If you were unable to interpret the flow volume loop, you would read this information and think the patient had obstructive disease. Interestingly, you're given two options for obstructive disease: dilated bronchioles, correlating with bronchiectasis, and or chronic bronchitis. Both these represent obstructive disorders and would have a curve that looked more like this, with an increase in the residual volume. The verbiage also includes weight loss, and to be sure, the only reason that is put into this clinical vignette is to tempt the individual who cannot interpret the curve to choose that the patient has a carcinoma. So finally, here we have the identifying information: swelling of the wrists, swelling and stiffness in the fingers and wrists over the last several months, suggesting the patient has rheumatoid arthritis. The worsening exercise tolerance in the presence of restrictive curve tells us the patient has interstitial fibrosis, complicating rheumatoid arthritis. And that is today's question of the day.